everybody again. My name's Michaela Nuttall. I am the clinical advisor for the cardiovascular prevention team here at Public Health England. Today we are joined by two people. We've got Tracy Bignell, who is the Senior Policy and Practice Officer at the Waste Equality Foundation, and Jabir Butt, the Chief Executive at the same foundation. I'm just going to spend a moment telling you about our two fantastic speakers that we've got for you today. So Jabir has gained international reputation for evidence, which I know is very close to all of our hearts, to make sure everything we do is evidence-based, and developing interventions that really help overcome discrimination and disadvantage. And he's written the award-winning guide for better practice in housing for disabled people called Different Paths. Many of you will have heard of Sure Start, and he's been used to and his evidence and his studies have been used to inform government thinking for interventions such as this. Jabir continues to write and produce lots of really useful information, I think, not just for people, but for at government level as well. And he's received an OBE for his work in 2013 on his work promoting race equality. In the double act today, we have Tracy, as I mentioned. Here is the Senior Policy Officer, and she's got 20 years of experience in policy and research and practice development with a variety of different organisations. And her groundbreaking research was a study of young Black and minority ethnic disabled people's experience on independence, and actually resulted in the press publication of something called Between Ambition and Achievement, as well as a study of informal support groups, which has led to a report Something to Do. Now, most recently, Tracy has led on the implementation of a community-based project, which is what you're all here to listen to and look at today, on raising awareness of high blood pressure amongst Black, African and Caribbean men, offering blood pressure in community settings. So today we have our 45-minute session, which will take the format of our two guest speakers, of which I've just mentioned, and they'll be talking for about 25 minutes, and then we will go into our Q&A section. And I'm sure many of you have got questions that you've already had in your head and you want to be able to ask, and I'm sure more will come out, and I'm really looking forward to the discussion that this will generate. But for me, my last bit before we start is just to say thank you to everyone who's joined us, and a huge thank you to Tracy and Jabir, and to hand over to these guys now. So over to you. Thank you.
Hello everyone, my name is Jabir Butt, and thank you very much, Michaela, for that introduction. It's always embarrassing to have some of your biography read out before you speak. Hopefully it's made you more interested in what you've got to say, rather than concluding I'm too full of myself. But anyway, hopefully we've got an interesting session ahead of us that Tracy's going to lead. But in opening that, I just wanted to make a couple of remarks. Firstly, this project is a collaboration between us and other members of the BCSC Health and Wellbeing Alliance, some of whom are with us in this session as well. Faith Action were one of the partners, as were Men's Health Forum, as were Clinks. And if you go onto our website, you can see more about the Health and Wellbeing Alliance and who's involved in that. Importantly, that alliance works very closely with Public Health England, NHS England, and the Department of Health in trying to better ensure that the voluntary and community sector engage with the development of health and care, and ensuring that it addresses issues such as health inequalities. The particular area that we're focusing on today, I suspect many of you will be aware of already, but perhaps has been given greater significance in the impact of COVID-19. We've begun to better understand the racial disparities being experienced by communities and the disproportionate impact that COVID-19 has had on Black and minority ethnic communities, as well as had on men in terms of the worst outcomes as a result of getting an infection. And I think a key element of that is, what is it that we can do to ensure that those poor outcomes aren't replicated and aren't repeated. And a particular issue is whether or not there are preventative activities that we should be involved with that can do things better. And what Tracy's now going to talk to you about, hopefully, is one example of an approach that might provide us lessons for future action as well. So over to you, Tracy.
So just as the project, it was a 6-month project. We started in September 2019 and it finished the end of March this year, 2020. And as I'm sure you're probably very much aware, that undiagnosed high blood pressure is associated with a number of cardiovascular diseases, and it's said can account for about half of all the heart attacks and strokes that happen. We know ethnicity is a risk factor to high blood pressure, particularly if you're from an African or Caribbean background, and men are disproportionately affected by high blood pressure, which I think Jabir had mentioned. And in terms of the sort of policy and the work around prevention, we know the 10-year cardiovascular disease ambitions for England aims to reduce health inequalities in addressing the prevalence of cardiovascular diseases. And in terms of high blood pressure, the intention is to increase the number of people who are diagnosed and are treated for high blood pressure, and particularly that routine blood pressure checks can happen within the community or healthcare settings. So within that context, I think the community blood pressure project fits in quite well. So the overall aim of the project was to address health inequalities through a targeted blood pressure awareness program and testing for Black, African and Caribbean men. And our intention was to develop a community-centred program, and we'd offer blood pressure testing in 2 pilot areas, and also raise awareness about high blood pressure and some of the implications for health for the African and Caribbean men. So I'm going to run through how we developed the program, some of the implementations, the key findings, and some of the learning from the project. In terms of developing the program, we did what you would expect. So we carried out a literature review, and we really looked at sort of screening programs, targeted health prevention programs, and the interaction with men, particularly Black men. And some of the evidence is that people who are lower socioeconomic status or from Black and minority ethnic background are less likely to take up screening offers, so for example around bowel cancer. And when you look at specific conditions that affect Black men, so for example prostate cancer, some of the other issues that impacts on health-seeking behaviour. So some studies have shown that prostate cancer isn't always seen as a disease that affects Black men, or it's seen as something that's part of the ageing process, and so on. So we looked at all these different factors that can impact on African Caribbean men and their involvement in testing for health conditions. We also had a co-production group, and that was made up of the partners, as well as ensuring we had African or Caribbean men who had high blood pressure or another long-term condition, so that they can inform what we were doing, how we were doing, and how it could be perceived by the men we were targeting. We developed a community blood pressure referral pathway, and this obviously took the basis of the NICE guidelines around high blood pressure, and we had input from GP leads in developing that pathway, so it was relevant and correct. And we developed targeted resources for the men. At the same time, while we were undertaking the programme, we had a process evaluation which the University of Bedfordshire undertook, and that looked at things around the implementation, so what we expected to do, how we implemented the project, any changes, and so on. And there were also a survey, sort of interviews with participants, so some with the men, but also the stakeholders as well. So in terms of the programme, we identified 2 areas which had the African and Caribbean population that we we needed. We looked at the hypertension challenges within these two CCG areas. So in terms of if they had something specific they wanted to focus on in terms of the African Caribbean community, targeting men, and how what we were doing could support some of the priorities that the different areas had. We had to get the interest and agreement from these areas, so that was from the CCG, because we needed the practical support. So we needed to have the healthcare practitioners attend the blood pressure testing sessions and carry out the blood pressure testing, and we needed to have the relevant community venue for the men, because we know that we need to have a medium that was trusted by the African and Caribbean men, and somewhere they feel comfortable. This quote is from some work that looked at public health interventions for men and African Caribbean men, and it says that barbershops would be a good place to promote health education and health promotion about the taboos, and also churches. In talking to men in barbershops, you would be surprised at how much they know. And indeed, you know, the barbers were a place there would be social interaction, peer support, you can relax, you can talk, and obviously get a haircut, because that's where the men, that's why they went to the barbershop. We ensured we had specific targeted resources, because in looking at some of the research around some of the health prevention, some of the issues that came up, for example, that, you know, men thought the resources weren't for them because there were no images, it wasn't speaking to them. So we had to make sure that our main resource was targeted at the men in terms of the imagery, the language, the structure, etc. So this was the one of the two leaflets we developed. Inside there was some information around high blood pressure and also sort of healthy lifestyle. And then the back page is where the blood pressure reading was written down, and the venue, etc., in case the men needed that, particularly if they had to wanted to show it to a healthcare practitioner in terms of their blood pressure reading. So looking at how we implemented the project, although I did say earlier on we were tasked with working in 2 areas, we actually worked in 3 areas, and that's because we had contact with a barbershop in another area who were quite keen to participate. They really wanted to have this health intervention in the barbers that they had. So we ended up working in 3 London boroughs. We worked in 5 barbershops, 1 church and a bus depot. We were successful in getting 87 men to participate in the sessions, probably more than I expected. So that was really very good. And we had, the majority were from the African ethnicity, so we had 48 African men and 29 African Caribbean men. The majority, I say over half, so 47 were over age 40 and above, so they were within the age group that were eligible for their NHS health check. And we worked with a range of healthcare practitioners, so a senior pharmacist, advanced nurse practitioner, nurses, a student nurse, and a healthcare assistant. We advertised the blood pressure session because obviously we're trying to raise awareness around high blood pressure, and we use the resource for that, but we also wanted to make sure we had a good reach. So where we were having the sessions in the barbershop, it wasn't just the men who would be coming to the barbershop, it was a wider reach. So if someone saw them through the social media, there was a session going on to get your blood pressure tested, that will be an invitation for them to come along. So the different venues use social media, they use the TV inside the barbershops to advertise the blood pressure testing events, WhatsApp, the church raised it at some of their services, the bus depot had posters and spoke to some of the drivers. And in terms of how the men found out, because we in the evaluation they were asked a bit about how they found out about the session. So some of the quotes were, "I have seen it on my barber's social media, on Instagram." Another one, "I came here, but I've seen the poster before, maybe online." And we did have posters up within the different venues, but obviously they promoted it as well. And these are just some other images in terms of how the session were promoted on a website, a session within a barber shop with the nurses and social media, and in the church where they set up a specific session which ran on a Saturday afternoon for men within the congregation and wider to attend. In terms of some of the key findings from the project, we found there was a real willingness to take part in the pilot blood pressure testing sessions, but there were still some issues within that. So some of the men had a bit of a misunderstanding as to what high blood pressure is, and it was quite useful that we had our main information leaflet, but we also had information from British Heart Foundation, NHS Health Check leaflet, other information that we could use to explain about high blood pressure. There was a misunderstanding around symptoms, and this was quite interesting because some of the men had the perception that you had to experience certain things to know you had high blood pressure. So, for example, one of the drivers who I was speaking to about the testing, who declined to get tested, and that's quite fine, it's within his rights. So we were talking about high blood pressure, and he was saying he had no symptoms, and he had no symptoms because his heart's not pounding really fast. And he didn't understand that sometimes there isn't any symptoms. So there was a misunderstanding there. We also had in a barbershop where another man stood up, pushed out his chest, and he said to me, "Look, I'm really healthy, I'm strong, I have no problems in my health, I haven't got high blood pressure." So there is, people sort of not knowing about, you don't necessarily need to have symptoms to have raised or high blood pressure. The only way you would know is if you actually have a blood pressure reading. But what I would say is that some men were aware that high blood pressure, that there's something to do with having too much salt in your diet or maybe too much alcohol. So they had a bit of information, but not necessarily all the information to have a real clear understanding. There was also a lack of knowledge as to what's involved in getting your blood pressure tested, and this was quite funny in some ways. We had a few men who just sort of have said, well, no, they're scared of needles. They can't get their blood pressure tested, they're scared of needles, and they thought having a blood pressure test meant having a blood test. So there is something about people knowing what's involved and how that may impact on whether or not they decide to participate and find out whether their reading is high, whether it's normal, whether it's low. Stakeholder assistance was really key to trying to get men to take part in a session. So we had the pastor in the church. He was the first person to get his blood pressure tested. He also rang a few men within the congregation to remind them they were coming along to a session. Some of the barbers got tested, and then what they did, while they were had men seated in the chair, they would talk to them. They would talk to the one who was waiting and said, "Go and get your blood pressure tested. It only take about 10 minutes. You still got your place when you come back." And they'd also have a conversation generally and wider around health, around food. So they were really keen trying to encourage the men to get their blood pressure tested. And they also talked about, the implication, the high levels within the African and Caribbean community. So in terms of the readings, because obviously we wanted to make sure if people had a high reading or a low reading, that they knew what the next steps should be. Of the 87 men, 17 had a reading that was higher than the NICE recommended levels, so it had a reading of over 140 over 90. What was concerning in one area where we worked in 3 barbershops, and they were all African barbershops, that in one of the shops, over half of the men, so 9 out of 16, had a reading that was much higher, and they were advised to go to their GP practice to get tested within a clinical setting. They were referred to take up the NHS health check, which quite a number said they had received information but hadn't gone along and hadn't done anything about the NHS health check, or they weren't really sure what was involved. The feedback has been positive for those who took part. Access issue came up particularly for the bus drivers, and in this quote that it clearly demonstrates why this person found difficulty in getting appointments and getting their blood pressure tested. As he said, it's very good to have it at work, so it meaning the blood pressure testing, because try booking an appointment at the doctor is very difficult. Sometimes you have to be on the phone very early in the morning and be on the phone from 7:55 to get such an appointment in the evening, but bus drivers don't have regular times. So you see, coming here is very beneficial for everyone. And others talked about it being good, particularly if they don't want to go to the GP. And we know that men are often engaged less with health services, and also the convenience of having the blood pressure testing in a community setting or in the workplace locality. We did have some suggestions for improvement, and that was more the fact that the men wanted this to have the programme running over a longer period of time, and it should be something run more regular. So they talked about employing more people, running it in different settings like shops, etc. The only issue that came up that was we would need to consider was the issue of privacy. So this is a response from one of the men. It is people's privacy, that's the main one. People come to the barber shop and they got a relationship with the barber, and they did not come here for this, so they didn't come to get their blood pressure tested. And what we did, we went along to the barber shops, all the settings, to make sure there was somewhere for the practitioner to wash their hands. There was an area for us to do the blood pressure testing, and some of the barber shops had back rooms, so they were quite hidden. But of course, for some of them, you were actually in the barber shop, and maybe that was too open for some people to participate. So in terms of the learning from the pilot programme, I would say that the buy-in from the CCG and the public health is actually key. They help us in getting the practitioners there who we need to do the blood pressure measurements, and it's also helpful to see how work that's happening in the different aspects within the community can feed into the local priorities around high blood pressure and cardiovascular risk within for the CCG and the public health team. It's important to build relationship within the community settings. So what we did, we went along, introduced the project, spoke to barbers, spoke to PASTA, spoke to the bus depot, their interest and agreement. But between the initial contact and when we actually ran the session, there was a lot of communication. There was WhatsApp messages to the barbers because they weren't using emails, phone calls, popping there to see them. As one barber said to me, "Oh, I remember you, you're the woman with the red hat who came a couple of weeks ago." So it's building that relationship and that trust, and that was really key to having a really successful session within the community setting. Having a healthcare practitioner present was really, really good. I think we didn't necessarily want volunteers to be running the session. We wanted the men to feel confident that if there were other issues they wanted to talk about around health that related to high blood pressure, they could, and they would get that advice. So, for example, in one session where we had a senior pharmacist, one of the men had a conversation around blood pressure medication, because as far as he could see, if your blood pressure is high, you get put on medication and that's it for the rest of your life. And he didn't have the right medication. So it was a very long conversation. I think both the senior pharmacist and the participant found it a really useful conversation. The confidence and competence of the health practitioner within the setting. Now, in terms of the confidence, obviously we were working in a different setting to what the healthcare practitioners are used to. So we're in barbershops, we're in a church, in a bus depot, and you know, some of them, and I'm thinking about a few of the nurses were comfortable in one setting more than the other. So one nurse didn't particularly feel comfortable coming to the barbershop, but she volunteered to do the session in the church. We had a healthcare assistant who came along to one session but didn't feel comfortable and didn't come back to another session. So there is something around the confidence of the healthcare practitioner, but also the competence in terms of knowing about the men, their lifestyle, their community. So particularly where we had the African barbers, we had an advanced nurse practitioner who, she came along, she pronounced the men's name correctly, she asked about the men's pronunciation, talked about food, she asked them, what are you eating, and had a wider knowledge, and actually you could see they felt quite comfortable talking to her. She was very confident and competent within that setting. So I think there's something about having that knowledge and an awareness. There was an issue about fear that came up, and this was really what other men had said about some of the men who were reluctant to take part. So, for example, within the bus depot, where one of the drivers had said, well, you know, one of the issues that there's a fear, because if someone takes part, their blood pressure readings are really high, then we have to think about work, the impact on work. So there's a fear that if your blood pressure is really high, it will affect your employment. Although, having said that, within the bus depot, they had regular health checks. But also that you would have to do something about it, and maybe it's better keeping your head in, you know, putting your head in the sand and not thinking about it. So there was some kind of fear, and maybe thinking about how you could sort of mitigate that, what could be done to alleviate that, and encourage the men to get their blood pressure read. Language was a learning point for us, more so where we had sessions with the African men. So some of the men had limited English, and you know, a barber would help interpret. We had an example where a man had a blood pressure reading. It was perfect, but he was concerned because his pulse reading was quite high. But what had happened, he'd arrived, he was rushing, and so the nurse explained, well, once you calm down a bit, it'll probably be fine. He had a second reading and that was fine, but yet he came back over and over again because he really didn't understand, and we had to get the barber to interpret for us to actually explain, and you could see eventually there was an ease within the man, that he understood what was going on. So sometimes language is an issue that we may not have thought about as much as we should have, and the timing of the session. Because obviously we want to not disturb the community venue too much in what they generally do, but try and fit in with their practice. So it'll be at a convenient time for them. So the bus depot, it'll be a time where they felt there were men starting their shift, finishing their shift, having lunch. There was a particular afternoon that would work well. And with the barbers, it may be late afternoon until evening when they had a majority of men attending. I just want to briefly just mention a couple of things in terms of dissemination. So what we have done, and we're quite happy to, is talk about the session to anyone that's interested, talk about the project, and we've already had a presentation ready with Public Health England. We do have the report, the project report, the evaluation report and the resources on our website. And if there are any other ways in terms of disseminating the findings, we'll be quite happy to hear about that. And I think I probably end now because I've probably gone over my 25 minutes, but I don't have a clock in front of me to see.
I was letting you have a couple more minutes for the delayed start, so
okay.
if you've got a little more, if you'd like to.
No, that's fine. I mean, the only thing to add is that what I've done is just a participant's view, which is that I would say the majority of the men, probably 99% of the men, were really positive about us coming into the setting, particularly the barber shops. They were really keen for us to come in there and to run this session. And so I put up this quote which just says, "It's good to find out if your blood pressure is okay, and if it's not, then I will get advice from the person doing it about what the next steps are from there. I get peace of mind that my blood pressure is all right, so I'm going to watch my diet. And I exercise now and then when I get a chance as well. So it's good. Well, I did want it checked. I was thinking about making an appointment, but I just didn't know when." So that's the response from one of the participants, and that was the sense of the feeling that we got from the men who took part in the sessions. So I think I will end it there.
Lovely, thank you, and thank you so much, actually, Tracy and Jabir. That I've been looking forward to hearing. Well, of course, chairing these guys, but hearing about your session, because sometimes just getting right out there and doing the stuff is really enlightening and empowering for taking things forward. And often we assume things, and it's only when we get out there that we really learn about it. So thank you.